So we'll continue on with a few more terms that use the combining form meno, and we call these menorrhea terms. So amenorrhea would be a situation without menstruation. If it's a young female, then that's very likely the case. If they're past the age where menstruation should have started, then that might be a concern. Or definitely for a mature woman who has normal menstrual periods, if amenorrhea presents, that could be complicated. Of course, at the other end of the spectrum, amenorrhea does occur occasionally as the female approaches menopause, which is something we'll talk about a little bit later. Dysmenorrhea is painful menstruation, and that's relatively common symptom amongst females who have, sort of the middle schmerz we mentioned earlier. And oligomenorrhea is scanty or infrequent menstruation. Once again, if any of these are deviations from normal, it never hurts to check in with a physician who knows you, who you've seen for a while, to make sure that there haven't been any major changes. The absence of a period when there should be one, or the onset of menstruation when there shouldn't be one, each of these are concerning symptoms and should be reviewed by a doctor. This is something we don't see much of anymore. This is going back in time quite a few decades, but it is still a potentiality. We saw it primarily in the 70s with the onset of the use of tampons. Toxic shock syndrome. This is a rare, sometimes fatal staph infection that occurs in menstruating women. It typically happens with the use of tampons, as I mentioned earlier. So you have typical staph bacteria that is in your body, and it's on skin primarily. You always have staph present. It's part of our makeup. If staph has an overgrowth somewhere, let's say, well, we could talk about streptococcus. So we can have an overgrowth of that, say, in the throat. That's called strep throat. So these are bacteria that are normally on the skin. Staph is very normal. It's on the skin. But sometimes it can proliferate in places we don't expect it. The uses of tampons and not changing them on a regular basis, or forgetting one's in and inserting a second one, which is more common than you would think, can result in something called toxic shock. Once these toxins enter the bloodstream through the vaginal wall, they can be very challenging. They can cause fever, abdominal pain, and all sorts of things. So it's something we are aware of, but it's not a pathology that we see a lot of in current medicine. Now, I mentioned earlier something called menopause, and the suffix associated with that is pause, which means ending. Menopause is the end of menstruation. Perimenopause is the period before menopause, so that's usually the years leading up to when menopause itself will occur. And postmenopausal is pertaining to after menopause. We see a little cartoon here at the bottom that kind of deals with some of the menopausal symptoms, hot flashes, and so on and so forth. Usually occurs between the ages of, say, the late 40s and the early 60s, and everybody's different, so there's variation in there. There are certain symptoms associated with it. Once again, there can be mood swings, and there can be, hot flashes, things like that. And just to be aware, ladies, menopause is associated with women, but men go through their own form of menopause when hormone levels are dropping. And so in men, as we get older, testosterone levels drop, and we have our own form of cycle. For women, the menopause cycle usually goes in periods that are equal to the menstrual cycle, so about every 30 days. For men, the cycle completes about every 6 weeks. But some of the very same symptoms in both genders, interestingly enough. And once again, that has to do with the fluctuation and the depletion of certain types of hormone levels. Which just brings us to the topic of hormone replacement therapy. These are oral or injectable synthetic hormones taken to correct a deficiency in hormones. The primary ones are estrogen, testosterone, and thyroid hormone. Now, thyroid in and of itself can be an issue at any point in life. There is a condition called, or two conditions actually, hypothyroidism or hyperthyroidism. And those can happen, once again, either gender, any age. They develop for various reasons, not related to specifically reproductive process. However, in the particular situation we're talking about here, menopause, as I said, means deficiency of hormones. It's one of the things that's going on. Some people tolerate this time period. For some people, it doesn't affect them much at all. For others, it can really change life entirely. So hormone replacement therapy, HRT, is available. When it first hit the market back in the 80s, they started using it all the time. They thought it was a form of miracle drug because it ended the symptoms associated with menopause for women. The downside of it was they found it also raises the incidence of breast cancer considerably. The common practice of hormone replacement therapy that I'm familiar with in the practices where I have worked says that most doctors are reluctant to prescribe it without a lot of consultation, first of all. If they do prescribe it, it's for a specific reason, and usually it's to try to alleviate the mood swings. And it does require yearly mammograms because of the increased incidence of breast cancer. I know many physicians who practice in general health but do handle gynecological issues who prefer to not use hormone replacement therapy if it can be avoided. But if it's needed, they will prescribe it, and most times it's a lifesaver. Once again, you just need to be aware, the patient needs to be aware, rather, that it does increase the incidence and potentiality of breast cancer. Another pathology associated with the reproductive system, dyspareunia. So pareunia is intercourse, and in dyspareunia, it's painful intercourse. It can happen for various reasons. Could be emotional, could be physiological, could be anatomical. In this case, they show a couple examples here: yeast infection, vaginal ulcer. So these things would be, of course, discomfort and would need to have medical attention. Dyspareunia is not uncommon, and it's an affliction that rarely is chronic. It's more acute. Usually there's flares here and there, and then, things move on. Sometimes it is a life-changing event. So we're going to go to talk specifically about the uterus right now. You see it depicted here in our diagram. So just to review, we started out with the ovaries, and they release the ovum, which go into the fallopian tubes or the uterine tubes, and via peristaltic contraction, they will embed the ovum into the lining of the uterus, and that's preparing that ovum for fertilization. We have three combining forms with uterus. We have utero, hystero, and metro. Let's go ahead and cover the first one. Utero, in terms of uterus, some of the words: uterine would be pertaining to the uterus, as in the term uterine cancer. Uteroplasty is a surgical repair of the uterus, so there may be a uterine prolapse, in which case they have to do well, actually that would be a pexy, pardon me. Plasty would be surgical repair. So let's say, classic example, a C-section, cesarean section. Part of the uterus is going to be incised to remove the baby. So uteroplasty would be a follow-up procedure to that. Uterovaginal would be pertaining to the uterus and the vagina as a unit. You can see here that they are very well connected. What separates them is something called the cervix, and we're going to talk about that a little bit later. Combining form hystero, a couple pages of words here for you on this one. Once again, still means uterus. Could have hysteralgia, which is pain of the uterus. A hysterocele will be a herniation of the uterus. Hysterospasm would be a spasm of the uterus. Hysteroscopy would be a visual examination of the uterus. So we saw an example of this before when they were doing cystoscopy, and there was a similar diagram that showed the scope going into the urinary bladder. In this particular case, it very much looks the same. However, the route of the scope is slightly different, and here it is used to look at the inside of the uterus. So looking for pathologies or anything else that might be of concern to a physician or might be causing symptoms. And to continue on with hystero, we also have hysteroptosis. This is what I was thinking of earlier, the second word, hysteropexy. So I confused it at the moment in that previous slide. Hysteroptosis is a prolapse of the uterus. So the uterus, once again, goes someplace where we wouldn't expect to see it. Hysteropexy would be the procedure that would fixate it back into the position that it should be. So, in other words, surgical fixation of the uterus, and that's hysteropexy. So we see here on the far left the normal position of the uterus. And on this moment, I just want to take a moment to say, look at the relation of the uterus to the urinary bladder in the female anatomy. If you've ever wondered why women who are pregnant need to use the restroom so much in terms of urination, well, there's the answer right there. When a baby starts growing in that uterus, it starts to expand, and look at all that weight. It bears directly down onto the urinary bladder. So and it takes a lot of space. The baby will take all the space it needs. So that pressure on the bladder is one of the reasons that the volume of the bladder is decreased during pregnancy, hence more frequent urination. So polyuria would be a symptom of that, although it's not a dangerous symptom. It's one we expect. The slide next to it, moving right, that is a prolapsed uterus. So in this case, the uterus is slipped out of the position it's in, and it's actually gone down the vaginal canal, and it's presenting outside of the body. And I haven't personally seen this, but I've been involved in cases where that has happened. And so I've always, been involved in setting that patient up and seeing their care through. Haven't actually seen the examination, but I've heard it described to me enough by doctors that I can say that the way it's depicted here is a reality, or potentially can be a reality. And also using the term hystero for uterus, we have the hysterectomy, probably the most common term involving the word hystero. This is excision of the uterus. So we have different versions of this. You see the radical, that's the old school method back in the day when they didn't know how to isolate, and they would do open pelvic surgery and just remove all the structures. It is still done today if needed, but they're more selective about how they go about it. You have a partial hysterectomy. You see that on the left. And the partial is taking just the uterus itself. The ovaries and the fallopian tubes are going to stay in place. Now, it's important because the ovaries also produce hormones. So if they're removed, hormone replacement therapy is something one would have to do, and that's in the radical. And so they try to avoid doing that. They try to be more selective. The difference between the partial and the total, you'll see that in the uterus is removed only in the partial, and in the total, they take the uterus and the cervix with it. And of course, once again, radical, they take all structures. And another name for a radical is a TAH, a total abdominal hysterectomy. We also have a procedure called a hysterosalpingo-oophorectomy. Now, I do know instructors who start their semester on this word because they want to show you how complicated it can possibly get. I choose to review it later in the class so that you feel more comfortable with compound words. So once again, hysterosalpingo-oophorectomy. This is a surgical removal of the uterus, the fallopian tubes, and the ovaries themselves. So in this case, you're seeing what's called a total hysterectomy on top, where they're taking, basically in this slide, they're taking the entire uterus. That's a total hysterectomy. In the total hysterectomy with salpingo-oophorectomy, you notice they're taking the entire structure out. So this is another form of the radical hysterectomy. They're basically leaving none of the anatomical structures behind. The big difference, though, and if you look at the other slide, you'll see this. The big difference is in the total, the TAH, in this illustration, they're showing that they're taking the cervix, but the vagina stays intact. And if you look at the previous slide, once again, that radical also includes excision of the vaginal canal. So that doesn't happen in a hysterosalpingo-oophorectomy. Typically, by the way, you don't see the hyphen in the word. They put that in because it puts 3 O's in a row, which looks very confusing. So that's why we have that separation there. Okay, that's all for this segment. I'm going to pause it and be back in just a moment, and we'll start covering some more topics pertaining to the female reproductive anatomy.